All right, legal authorization for organ donation. So I really want to peel this back to the core because the framework for organ donation and the law that establishes how we go about obtaining permission for organ donation is really fundamental to the entire approach, including how we've organized our opt-in system in the US. So with that, I do want to start with another question. I promise you it's not going to be polling the whole time, but there's some in the beginning here so I can get a sense of kind of where we're at with all of you. So let's move on and see. The law requires informed consent to authorize organ donation. And I do want to say, if you're a knowledgeable insider, maybe hold back. So that we have our individuals that are here to learn for the first time have an opportunity to express their opinion. Okay, so we've got 14% on true, we've got 86% on false. I'm sure there's some number in this group too that didn't vote because you're like, that's why I'm here at this symposium, because I have no idea if this is true or false. It's probably a trick question because I know you're an attorney, so I'm not answering it. Well done, well done. No, it's not a trick question, but in fact, actually the answer is false. The law does not require informed consent to authorize organ donation. And I think that people find that surprising, and especially healthcare workers find that surprising, because if you work in healthcare, informed consent is really the principle that you work with every single day. And so it's really different to think about permission using a totally different principle than informed consent. But that is, in fact, what happens with organ and tissue donation. So organ and tissue donation follows the Uniform Anatomical Gift Act. And this is in part why we use the word authorization. So authorization and informed consent really mean the same thing, which is permission, legal permission to move forward. But we use the term authorization to distinguish the process for permission for organ donation from the term and the understanding of informed consent in the healthcare context, which is really something different. Because informed consent is a facilitated understanding of risks and benefits of a particular treatment alternative that a patient might be, or a surrogate might be making a decision about. Right? But there are no risks or benefits to a deceased donor with organ donation because the donation is going to occur after they have died. So there's no risks and there's no benefits. And the law recognizes that by setting up a legal framework that utilizes a different set of principles than informed consent, because there's neither risks nor benefits. Instead, it's an authorization process, straight out legal permission. The Uniform Anatomical Gift Act also sets up some conditions. So the gift is conditional on death. The individual has to die for the gifts to be coordinated, right? So the recovery of the organs is going to take place after the individual has died, and on clinical suitability. So individual might register to be a donor, but if they die in a manner that's not suitable for organ donation, or they have other conditions or diseases that preclude organ donation from occurring, then that gift's not going to be completed. So clinical suitability is another condition, so to speak, of the gift. And then finally, the law also imposes certain limits to the purpose for which the gift can be used. So it can't be just used for anything. Specifically for transplant or therapy, which is prioritized under the statute. And then also the gifts can be used for research or education. So if an individual just makes a general gift, they've registered at the RMV when they renew their license, then transplantation is going to be prioritized if the donation can be used for transplant. That will be given priority. So this Uniform Anatomical Gift Act is a uniform law. And what that means is it's a state law, but it's been enacted in every single state in the country so that there's uniformity in the policy and the framework of how organ donation and tissue donation is authorized throughout the country. But it is not a federal law, it's a state law. So that's an important piece to understand. So the next point to make is that the Uniform Anatomical Gift Act sets it up so that an individual can make their own decision. And we call this first person authorization, which I find to be kind of a little bit of an awkward term, first person authorization, but really all it means is that an adult can make their own donation decision before they die. And that if an individual doesn't make their own donation decision, then a surrogate decision maker can make it for him or her at the time of death. But that the priority is for an individual to make their own decision in the first instance. And that's actually been true since the beginning. The Uniform Anatomical Gift Act was first enacted in 1968, which was really only a couple of years after the very first transplant took place. So lawmakers were kind of on this, surprisingly, because that's not always the case. And they set up this framework that's really endured the transformation of donation and transplant from the nascent kidney-only circumstance to kind of where we are now. But it's important to understand that this idea of individuals making their own donation decision has always been a central part of the legal framework. And that there's a really strong ethical basis of this. And I think most people recognize that this is really about autonomy rights, and that this self-determination concept for adult individuals to make their own decision about their organs and tissues after their death, and that this is quite consistent with the way the law looks at other ethical principles that support, for example, advanced directives, or even outside of healthcare, using property law, which the Uniform Anatomical Gift Act really is modeled after, things like how you might direct where your property goes in your will, for example, and that you have the right to do so as an adult, and that it's legally binding. Okay, so taking this concept of the Uniform Anatomical Gift Act, then our country has established a process of donor registration, which you all are familiar with, and we've talked about here a little bit earlier, I know, in the day, at least in regard to Utah. And if you were paying attention earlier, then you have a little bit of a clue as to where we might be here. Again, if you're a knowledgeable insider, I don't want you answering this. But let's see what we get. Don't touch it. I think when you do, is it still going? Oh, it's still going. Okay, that's good. That's weird that it kind of crunches it down, but that's okay. All right, we're still moving a little bit. Okay, so so we have, it looks like the most votes for 75 million, and then 25 million, followed by 165 million, and around 5 million with the lowest number of votes. So I think I heard that here in Utah, you have close to 4 million. Did I hear that right? 2 million. All right, sorry. I was giving you just 100% increase. Still, if you think about that, so 2 million in Utah, then we're going to have more than 5 million in the US, right? So this is pretty incredible, but we actually have 170 million registered donors in the US. This is as of the end of this past calendar year in 2023. And so this system of opt-in donor registration has actually been highly effective. Part of the reason that it's highly effective is it's really well aligned with this framework of the Uniform Anatomical Gift Act. Because one of the questions I get frequently is, well, I go to the RMV, or my family member went to the RMV, and that's not an informed consent process. Like, I just was asked to check a box or not, right? But the answer to that is it's not an informed consent process. It's not designed to be an informed consent process, and it doesn't need to be an informed consent process because it's an authorization process consistent with the Uniform Anatomical Gift Act, that as an adult, you can opt in to give permission for this gift, or you can decide not to, but it is not an informed consent process. And so that legal structure really supports our donor registry system, which has grown to be very robust. It has more than doubled since 2008 to 2023, which is just amazing. So there's multiple ways you can get on the registry, and I pulled this graphic online. I'm not totally sure if this is what your license looks like. I'm from Boston, and that's definitely not what ours looks like, but I'm told it's close. So as we've discussed, you can do this when you renew your license. You also can do it on your iPhone. If you have an iPhone, there's a health app. You can also go online to registerme.org. And in some states, you can do it when you file your taxes, or you can do it when you get a hunting license, or, there are multiple ways in different states that you can put yourself on the registry, but all of them use this same legal framework of the Uniform Anatomical Gift Act, that you're authorizing, giving permission for an anatomical gift after death. Okay, so if so many people are registered, 170 million people are registered, why is there a shortage? Right? There's 104,000 people waiting approximately today in the US, and we know that there are people who die waiting every day. So, oops, I gave away one of the answers. So, why is there a shortage? All right, I think, let's see, it looks like we get the most votes because only a small number of people die in a manner where there's medical opportunity for donation. And that is in fact correct. So if you look at this graphic here, and I'm going to go over this in a little bit more detail, but in the middle there, only about 2% of inpatient deaths have medical opportunity for organ donation. We talked about this a little bit earlier in the day today. And so that is really the biggest rate limiting factor. And to repeat myself a little bit from earlier in the day, this is why there's few kind of at-bat opportunities for organ donation. So every referral opportunity is incredibly important. Okay, so part of what I'm showing here is that our opt-in system has one really beneficial aspect to it, which is that there's two pathways to a yes. And what I mean by that is we have this ability to opt in to the donor registry. So 170 million people have done that. By the way, that's about 55% of the adult population. And in some areas like yours, it's a higher percent. And in some areas like the Northeast, it's a little lower. But is on average about 55%. But what our system also allows for is no decision. And in the case of no decision, then we have the opportunity, if there is a potential organ donor, to approach the surrogate decision makers, and you have family that can either authorize or decline in those instances. So that really gives us two opportunities to a yes. Sometimes I get asked the question, should we go to an opt-out system? Should we think about presumed consent? And aside from the cultural mismatch, which I think would be pretty large, to have the government say, we're going to assume that you want your organs donated unless you say otherwise. One of the things that opt-out does is it goes from a two pathways to a yes to a two pathways to a no, basically. You can opt out, and otherwise it's a presumed yes unless your family opts you out. So it's a kind of flips the dynamic here. And I'll get back to that a little bit later in the presentation of what those donation rates end up looking like. So our system design is actually functioning well. And what it's meant is over the past decade, we've had incredible growth. Had a 98% increase over the past 10 years, so about double the number of deceased organ donors over the past 10 years. And I think it's really important to say this is a little bit small, but that this increase in deceased organ donation has not been the result of the opioid epidemic. I have heard that sometimes in the media, or sometimes others within the medical community have attributed overdose deaths to the rise in organ donation. And while there's certainly been an impact, and you can see the blue line on the bottom there from 2013 to 2023, there's certainly been an increase. But the increase in deceased donors that have died of causes other than drug intoxication, which is how overdose is categorized in the death data, has greatly surpassed, excuse me, that of donors that have died of an overdose. So in 2023, for example, donors that died of causes other than an overdose accounted for 83% of all deceased organ donors. And I put this up here too because I think it's important to say that, one public health crisis shouldn't be fueling another one, that we're all in here to try and save lives. But that said, that donors that die of any cause contribute to this life-saving endeavor, and that the donations from donors that die of drug overdose or of suicide or of any other causes contribute just as positively to this life-saving mission, and we don't want to take away from that in any way. Okay, so one of the things that has contributed significantly to the increase overall in the growth of deceased organ donation is this rise in DCD donation. And I think everyone hopefully knows what DCD donation is. So donation after circulatory death, meaning that the donor is not brain dead, isn't going to meet neurologic criteria, the ventilator is going to be withdrawn, the patient will become asystolic, death will be declared, and then organs will be rapidly recovered. 388% increase in the past 10 years in the US. That's staggering. So this is really where the growth has been in the US in organ donation. And as a result, it raises a number of questions. So another one for you to answer. Legal authorization for DCD is different than when the patient is brain dead because the OPO is working with the family before the donor has died. Legal authorization for DCD is different because the family needs to give informed consent. Legal authorization is the same for DCD as it is for brain death. Legal authorization is the same unless it's a registered donor, then it's different for DCD. I know. What do we got? All right, so we have mostly on legal authorization is the same for DCD as it is for brain death in deceased donation. And that's correct. Great job, guys. That's correct. And so authorizing organ donation under the UAGA is about authorizing donation after death, regardless of how death is declared. So donor registration authorizes donation after death, regardless of how death is declared. So it does not make a difference under the law whether the patient is declared based on neurologic criteria, brain death, or based on circulatory criteria. The law makes no distinction in regard to authorizing organ donation. So authorizing donation does not also authorize withdrawal of support. And this is important to say because the withdrawal of the ventilator is a component of the DCD circumstance. But the law really sees that as separate, that is a component of the end of life decision, and a surrogate consent for the withdrawal is going to be required. So we do know that withdrawal must be done in a way that allows for DCD to proceed, but the permission is seen as legally distinct. So informed consent for the withdrawal, authorization under the UHCA for the organ donation to proceed. Which really brings me to the timing of the discussion and authorization for DCD, which is a key focus, I think, for OPOs and donor hospitals right now. And I want to talk a little bit about the dead donor rule, because sometimes the question comes up, and you guys didn't, there weren't a lot of folks that were answering this way, but sometimes when I give this presentation, the question a couple back on the poll of, well, we're talking to families before the donor has died, and therefore it's different, comes up. And the question specifically is, well, is there an issue with the dead donor rule? The dead donor rule is an ethical principle that the recovery of organs can't be the cause of the donor's death. It does not have to do with when the discussion takes place. It has to do with when the recovery of the organs takes place. And by the way, the dead donor rule is an ethical principle, but as a lawyer, I have to say it's also, kind of the law also, right? That we're not going to recover organs that in a manner that would cause the death of the donor. The donor needs to be declared first, always, and then the organs are recovered. So the dead donor rule doesn't preclude discussion of or consent or authorization to donation prior to death, right? And that separating out the withdrawal decision from the donation decision is one way to really think about all of this. So a number of years ago, the Institute of Medicine came out with a report kind of talking about the issue and some of the ethical considerations with DCD and permission for donation. And what the Institute of Medicine said was you really want to decouple these two things, that the decision to withdraw should be made independent of and prior to the donation discussion, and that there should be this firewall between the two discussions. But the context of this IOM report, which by the way was more than 10 years ago, was that there was always going to be a surrogate decision maker because the donor registries were not nearly as robust as they are now. There weren't half the potential donors registered making their own donation decision. And so the assumption in the Institute of Medicine report was that there was going to be a surrogate decision maker. But in fact, what we have now is especially with registered donors, it effectively decouples that donation decision from the withdrawal decision. I mean, the donation decision may have been made weeks, months, years, potentially decades before this withdrawal decision is being made. So it was made at a different time and in advance of the withdrawal decision. So ethically, we really do have that decoupling that the Institute of Medicine was talking about. And we would maintain the fact that separate surrogate consent is required, again, for the withdrawal and any pre-mortem procedures that might be required in order to facilitate the donation itself. Okay, so how do we go about doing all this? Well, I think hardwiring donor registration in DCD, understanding and having knowledge of the law is really important because these frameworks support why our system works, why the donor registry works as a legal matter, as a policy, how it all comes together on the ground in our practice, and having some confidence in the ethics of all of this. The autonomy rights, the self-determination, the decoupling of these decisions, and making sure that that timing is really addressed in the protocol. And I want to spend a minute kind of talking about that in a little bit more detail. At the OPO in Boston, where I work, we saw, this was now back a number of years ago, that we really had an opportunity to decrease timing as the reason for no authorization, specifically in DCD cases. And that what we noticed is that timing, when we asked families where authorization was not obtained, they said that you can see on this slide here that the majority would say that timing was the reason that they were saying no, that they were kind of done. They had made the decision to withdraw and they were done and they wanted to go home. It wasn't really an objection to donation so much as they just had it. And so we decided to do a pilot, and what we termed preliminary discussion is approach families earlier, before the withdrawal decision had been finalized, but when it was being discussed, and approach families about donation at that time and see what happened. And what happened was we got a much higher authorization rate. You can see this here. It was actually quite dramatic. 88.6% when we had preliminary discussions, 63.4% when we did not. And so this was a relatively short period of time, but when we saw how effective it was, we moved to do a rapid deployment, and in 10 weeks, we saw a 7% increase. So as you can imagine, this is now standard practice for our OPO, because this was now back in 2021. And now in DCD cases, whenever possible, we're doing a preliminary discussion. And we have found that that has been highly effective in meeting the needs of the family to really change how we've operationalized and challenge our own assumptions, and especially with our hospital partners, the assumptions of, when it's appropriate to talk to families. Families were saying, you're waiting too long. We wish we had known this information a day earlier and it would have been fine. And so we need to incorporate that back into our practice and our thinking, and understand that it doesn't undermine the ethics of what we're doing and is supported by the legal frameworks. So moving on a little bit, what do you do when you have this donor registration and the families are objecting? Can they override the donor registration? I've got a yes, no, and a maybe. See, and the maybes are kind of like, I know lawyers are kind of hedge everything, right? Because like my favorite answer is it depends, which is like a different way of saying maybe. But in fact, it's a no. It's a no. And in fact, I think one of the questions is, so the law is clear on this, and I'm going to get to this in a little bit more detail in a moment. Families can't override the donor registration, but that doesn't really answer what to do when you have a family objecting, because it isn't a legal issue. It's, how do you move forward when a family's objecting? So you've got knowledge of the law and ethics. Well, that's helpful, and hopefully things like this will get everybody on the same page. But then it's really about escalation protocols, making sure you understand the basis of the family objection. Was there a mistake or an error in the registration? I mean, that's one of the first questions we always ask. That's possible. That happened, by the way, in a case in New York. But that's unlikely, but you want to make sure not the case. Are there other factors or circumstances at play that you can address with the family? Have you assessed the transplant potential? I mean, none of us are doing this work to upset families, right? We're doing it for the life-saving benefit of the transplant and to carry out the wishes of the donor. And so we do want to make sure that there's been this assessment that there's an opportunity for transplant potential in this donation. And then, I think you really want to weigh the benefits and the risks or potential harms of moving forward. And in general, this is how it tends to shake out: respecting the autonomy rights of the donor, maximizing the potential good, which is lives saved through donation, a shared accountability for donation. I'm going to stop here for a second because, again, we in the US have an opt-in system of donation. We're asking the public to take that step of opting in. And so we have a responsibility. It's incumbent upon us as professionals in healthcare then to have some accountability to make that donation happen when there's an opportunity, which, by the way, is only about 2% of the time. So it's pretty rare. As a lawyer, I got to say, also kind of a benefit to comply with the law, right? This is good. And you'll notice I put media on both potential benefit and potential harm, because the media is going to show up on both sides of this issue. That the media is going to support the individual's right to make a decision and the life-saving benefit, and the media is also going to jump on an upset family and, you know, this caused distress. So I think we have to be realistic that the media is going to be in both places, but it's going to be in both places. Family distress, again, potential harm we want to avoid if at all possible. And I think, you know, unclear donor intent, I put that up there, but, you know, ultimately you have this gift and the law recognizes that it's binding. So all of the stakeholders that can help support families, reduce the conflict, figure out a path forward, ethics committees, leadership, both from the hospital and the OPO, legal, super important, not just because I'm a lawyer, but because it's actually not a legal issue. And if you can clear that one out of the way, then you can get to the other players who can be more helpful in really supporting families through this. Public relations to be prepared for whatever might come down. In terms of reducing the legal conflict, I already mentioned clear the legal standards. I think you want hospital policies that align with the law. That should be sort of table stakes already for you all. And then you want consistent communication that everyone understands that that is the law. And now let's figure out how to get everyone comfortable with moving forward. Okay, but then I always get people in the audience that are like, yeah, but what if? Like the what ifers. There's always what ifers, right? And so, so what if? Okay, so what if they say we're calling our lawyer? Great. I always support donor families calling their lawyer. That is an excellent next step, because a lawyer is going to tell them that the law is really clear. And it will be incredibly helpful if the donor family, if they want counsel, if they go get counsel. So I always encourage donor families to get counsel if that's something they're seeking. And of course, engaging OPO and hospital counsel, also important if you get to this kind of point. This is rare. This is really unusual that you're getting to this point, but I want to assure you that if you do, this is what it looks like. Clear documentation of the gift. Can you print out the RMV form that has a signature, or is it an advanced directive that has a signature? That's really helpful. We already talked about assessing transplant potential, so you know that there's this gift can be transferred and accepted to somebody else. That's the whole reason that the gift was made. And again, encouraging the lawyers to communicate early and often will help alleviate the concern that this is a legal issue. My favorite slide, the law is clear and it has your back. The law is incredibly clear on this point. And it does have your back, meaning all of our backs. It has the donor's back who made this decision. It has the provider's back who's going to follow that decision. And this shows up in the Uniform Anatomical Gift Act. And it shows up in a couple of ways. First, it says that the hospital should preserve the option of donation. We've already talked about this while you're trying to figure out what happens. So while there's a conflict and you're not sure what's going to happen, status quo prevails, right? That's what the law says. But more importantly to this particular topic, the statute also says that the rights of the person to which the part passes, which in the first instance is the OPO, just to recover the gift and to give it to the transplant recipient, are superior to all others, and that's really important. And then the last one is the good faith immunity from liability, which means that if you're acting in good faith, and this includes presuming that the donor registration is valid, then the law grants immunity from liability. And that is a complete defense unless there's any kind of question of fact about good faith. So if you are acting in good faith, then you are legally protected. This is incredibly unusual in a statute, and it's in every state, and it's been in the law since 1968. And yes, it has been upheld in court. And this is a very strong legislative policy to discourage lawsuits, which is what it's done. There's been very, very few lawsuits. because this is a very strong policy. All right, we'll see you in court. This does occasionally happen. It's rare, like I said. I think I can think of maybe 2 cases in the past 10 years that we've experienced at our OPO in Boston. It shows up as an emergency hearing. The legal standard for emergency hearings has to do with balancing the harms. We've already kind of talked about what that looks like. The likelihood of success on the merits, meaning what does the law say? We've already kind of talked about that. And what about public policy? And we've already talked a little bit about that. The public policy that the legislators chose is to promote donation and life-saving transplant. So again, in an emergency hearing, the court's going to look at the very same factors that we just discussed. So there were 2 recent court cases. When I say recent, several years in my neck of the woods in the country. And I'm not going to have you guess on this one because I don't think I've given you quite enough information, but I'm going to tell you that in both cases, the court found in favor of the donor designation and moved forward. And I think, to give you a sense of what kind of case, this was, I think, the most recent one, which was a 42-year-old. Now, here's some interesting facts. This is a brain dead potential donor in Massachusetts, but registered in Virginia. Uniformity of the law coming in handy, right? Because registered in Virginia, but it's the Uniform Anatomical Gift Act, and the states all give full faith and credit to registrations in other states. This could definitely happen here. You have people coming into your state for traveling through vacations and other reasons. The family objected, and they actually, although we were aware of the objection, we weren't aware of kind of how substantial the objection was, and neither was the hospital care team, but the family went to court and filed an injunction the morning that we were actually in the OR, but before the incision. So this was like a Grey's Anatomy scene going on. We had the heart surgeons already in the OR. Incision hadn't happened yet, but it was right down to the wire. And so the recovery was suspended. We had a virtual hearing. Of course, it was a weekend because that's when these things happen, right? You're in a hospital, you know this. All the stuff happens on the weekend. So it was a Saturday in July. And it moved forward. And it moved forward because, there was, I think I didn't put what the outcome was, and I should have, but the outcome was 4 transplants. The outcome was that the family was supportive by the time that the recovery took place, which was hours after the court opinion. And the family wanted an honor walk. So I can't explain that, but I can just tell you that sometimes it was like they just needed the court to say it was okay. And that's what happened. And the court said, this is what your 42-year-old son wanted. And the law is going to support that. And we're moving forward and 4 lives are going to be saved. And they said, okay. And that's then what happened. So I'm not suggesting that cases go to court. It is incredibly unusual. We're not in this business to go to court or to distress families, but we are in this business to save lives. We are responsible for following the wishes of those who have made this decision. And I do want to make sure you know that if it ever gets to this point, this is what it looks like. So understanding the legal standards supports sort of ethical practices in donation, and also sort of precision about how our practices work, that the recovery of organs is going to take place after death, that there's transparency on all of this builds public trust, which is how donation and transplantation happens. And ultimately, this leads to one of the best functioning donation and transplant systems in the world. This is an international comparative. It's from 2022 because the European data for 23 is not in yet. But in 21, we outperformed Spain. In 22, we came in second. So we'll see what happens in 23. But you can see there's a big gap between US and Spain and all of the other countries. We do incredibly well with our opt-in system. And we want to continue to do incredibly well for the donating public and of course for the patients who are waiting and counting on us to do that. This last slide is a sign in the hallway of the office of my OPO in Boston that we're impatient optimists. I think it really captures well the culture of organ donation everywhere across the country, that we're impatient for a future for where every individual who needs an organ transplant has an organ available, and that impatience sort of captures the urgency of the work that we do, and that we're optimistic that we're going to get there. And that optimism is certainly part of the hope that we bring to those who are waiting, but it's also founded on, our performance, that the system is improving at rapid pace and delivering for the patients in need. And that's true nationally. It's certainly true here. There's an awesome OPO here in Utah that has had incredible growth over the years and the recent past too.